alternative models to address quality of care for children with ASD. Our group consists of Jordan Johnson from Manistee, Michigan, taking the role of school psychiatrist. I am both for and against the medical model.
I'm Haley Chapman from Fort Worth, Texas, taking the role of a parent, and I am against ABA.
Heather Menzer from Mechanicsburg, Pennsylvania, taking the role of the BCBA and I am for ABA.
I'm Pua Quintana, and I am from California, taking the role of an occupational therapist, and I am for sensory integration therapy.
I am Courtney Miner from Indianapolis, Indiana, taking the role of a behavior therapist and against sensory integration therapy.
Hello, everyone. Thank you for taking the time out of your day to attend Josh's IEP. The purpose of this meeting is to discuss and work on finding the best interventions possible for Josh to be successful with meeting his treatment goals. Mr. and Mrs. Smith are here today to ask the team of professionals working with Josh for finding best and most appropriate treatment for Josh between medication, sensory integration therapy, and applied behavior analysis. Therapy team must use evidence-based research to select the best treatment approach for the child. If the BCBA does not use evidence-based research, it can violate ethical codes.
Josh has been demonstrating out-of-seat behavior and impulsive behaviors in the classroom, and we don't know what to do to help him. We are here to find the best approach to help Josh reduce these problem behaviors that he is exhibiting so that he is getting the help that he needs while in school.
I'm sorry to hear that you and your family are having to deal with these troubles. As a psychiatrist, I often see parents who are exhausted and overwhelmed by their child's symptoms. Due to your concern of out-of-seat and impulsive behaviors, possible medical interventions may help to reduce the impulsivity symptoms. Turek et al. 2013 state that medication helps target the externalizing symptoms of ASD, such as hyperactivity, aggression, and obsessive-compulsive disorders. Doyle 2012 also states that for the treatment of hyperactivity and inattention, psychostimulants demonstrate benefits. Research shows the success rate for stimulant use is nearly 80%. These medications can bring substantial improvement to impulsivity that undermines social, behavioral, or academic progress in a child with autism. Hazel 2017 states that problems of inattention and hyperactivity affect nearly one-half of individuals with autism spectrum disorder. Substantial benefit in reducing inattention and hyperactivity is seen with atypical antipsychotics such as risperidone and quetiapine. Medication can be a quicker solution and will require fewer appointments, less time off from work, and overall less energy. Medication is commonly used due to it being a quick fix approach. Within the following chart, it is showing all medications that are frequently used for inattention, hyperactivity, and impulsivity. It also shows over in the middle what healthcare providers, such as myself, monitor when a child is put on medication. And on the far right of the chart shows what educators and families such as yourself can work on to avoid potential side effects of the medication.
A quick fix does the medications will be safe for Josh.
That is a sound concern as a parent. I'm glad you brought that up. In fact, the U.S. Food and Drug Administration has approved 2 drugs for children and adolescents with autism. Risperidone and Abilify, both atypical antipsychotics prescribed for behaviors associated with irritability. In addition, there have been many studies done within the past that show effective use of medication on impulsive behaviors. The study by Nichols et al. 2018 show that stimulant medication is an effective treatment for the target symptoms of hyperactivity, impulsivity, disinhibition, and inattention for children with autism. Within this particular study, there were 124 subjects that had the DSM-5 criteria for autism spectrum disorder. Psychostimulants were used to treat 52% of the 124 subjects. The median total duration of psychostimulant treatment was 4 years. Within that time, there were 398 episodes of psychostimulant treatment. Favorable responses were associated with 69% of treatment episodes. These results indicate that psychostimulants are commonly prescribed for children with autism and suggest that these medications may improve the target symptoms of hyperactivity, impulsivity, disinhibition, and inattention.
Being the best option to adjust Josh's behaviors, and I'm not sure if I want Josh to be on medication that can make him not act himself.
I understand your concerns, Ms. Smith. As a psychiatrist, I have read many studies on the intervention of medication. A study by Crone et al. 2016 state that the cost of prescription medications are more than double the cost for children with autism spectrum disorder, compared to children without the diagnosis of autism spectrum disorder. But that being said, I will be honest when I say that when using medication, there can be some side effects that go along with the medication. Lavalo and Matson 2019 state that the side effects from psychotropics can be short-term, such as irritability and sedation, or side effects can be long-term, such as repetitive jerking movements that occur in the face, neck, and tongue, along with weight gain. It often isn't always easy to find the right medication for the child. It can often be a case of trial and error to find the right drug. This may be due to the fact that treatment of specific symptoms and then adding medication to treat the side effects of those medications. Within the above-mentioned study done by Nichols et al., out of the 398 episodes of stimulant treatment, 16.8% were associated with a documented side effect. At least one side effect was experienced by 66% of the children. Here you will see a chart by Bowker et al. 2011 that shows medication is on the top of the treatments list in order from most to least frequently discontinued. The discontinuation of services may be due to side effects, no improvement seen in symptoms, and/or pursuit of other options to address problem behaviors.
Leader and Hughes, 2011, individuals with autism spectrum disorder may struggle with integrating information from the vestibular, proprioceptive, and tactile systems, which ABA cannot address.
Based on the behaviors that you have described, in my professional opinion, applied behavior analysis would be the best and most effective route for you to take for interventions. ABA is controlled by a code of conduct that must be followed and adhered to. BCBAs must follow the code, and one of the main points is that they must rely on scientific knowledge and remain within their own boundary of competence which fall under the code's 1.01, reliance on scientific knowledge, and 1.02, boundaries of competence. According to Boker, D'Angelo, Hicks, and Wells in 2011, at that time, ABA is the most frequently used treatment, with 37.0% of families utilizing it. Families have overall seen a great reduction in target behaviors and much success with this method. Furthermore, Allen and Warzark 2000 applied behavior analysis have developed numerous effective interventions that can help with targeting common childhood problems and have proven repeatedly that the behaviors can change quickly with properly managed interventions. This must also follow the code of conduct in that the BCBA must follow to ensure that there is treatment and intervention efficacy, which is code 2.09, treatment and intervention efficacy, as well as ensuring the individual behavior change programs which is code 4.03 individualized behavior change programs. This could include something as simple as changing the seat to changing the overall environment in which the student is learning. As a BCBA, I would ensure that your child is receiving individualized programming which follows codes 4.03 individualized behavior change programs, and that they and you were involved in the planning and implementation of the program which follows code 4.02 involving clients in planning and consent.
Is punishment based. Is this true? I've read online that ABA is not as effective as some may see it. A lot of reasons for this are because I have heard stories and I'm afraid what has been done in the past will be done today.
ABA is not a punishment-based treatment procedure. It is based on individualized behavior change programs that are described in detail, which was noted earlier as code 4.03 individualized behavior change programs, and monitored to ensure that there is program success which follows code 4.05 describing behavior change program objectives, ensuring that the least restrictive settings and procedures are utilized, which follows code 4.09 least restrictive procedures, and that there should also be an assurance that there is no harmful reinforcers being used, which is code 4.10. Finally, if any punishment procedures would be used, according to the Code of Conduct 4.08, it states that the considerations regarding punishment procedures, the BCBA will recommend reinforcement rather than punishment, and whenever possible, but however, if it is necessary to use the punishment, there must be reinforcers in place too. As a BCBA, I would have to examine the information in great detail and determine what is best for the interests of Josh in his treatment.
I have also heard that ABA is expensive and time consuming. I'm not sure if I have the time every day that therapy is needed and if my insurance will cover what will be offered for Josh.
Overall, without insurance, ABA could be very expensive. However, your insurance company should cover the cost of all ABA treatments and interventions until the age of 21. It can be time consuming depending on the level of services that need to be provided. Services can range from as much as 25 to 40 hours a week for multiple years, or less at only 4 hours a week until goals are met. The level of consistency that you are also able to provide will help Josh be more successful.
I'm also afraid of how others react in social settings to Josh. Others do not understand our situation, so it is automatically judged for his actions and has a negative effect on us as a family.
An individualized treatment plan would be developed to determine what his target behaviors are and how to incorporate them, which follows code 4.03. I, as a behavior analyst, have the responsibility to ensure that Josh's best interests are being advocated for while working with multiple different parties, which follows compliance code 2.04, third-party involvement in services.
Pfeiffer et al. 2011 states the available research is limited in its concept because of design flaws and weak or ineffective outcome measures that produced mixed results. Research with the ASD population regarding the effectiveness of sensory integration treatment is difficult in general because of children's varying developmental levels and the shared nature of the treatment.
Thank you guys for all that information. So now I want to talk to you guys about SIT, which stands for Sensory Integration Therapy, and it aims to help kids with sensory processing issues by exposing them to sensory stimulation in a structured and repetitive way. These techniques have also shown to be very effective with kids with autism. Sensory integration therapy can be very beneficial for impulsive behaviors and reducing many types of maladaptive behaviors. It is not like ABA therapy where you sit on a table and run trial after trial and can sometimes feel very robotic. Sensory integration therapy can be very helpful and not seem like we are forcing kids to work. We can make it very fun while working and reducing behaviors. Sensory integration therapy is very unique and not like many other types of therapy techniques. We tend to use different types of equipment such as suspended swings, tactile brushing, ball pits, scooter boards, and many other types of equipment not normally found in a school or home setting. We also like to work in different environments such as gyms and even a horse track to change up how people think about therapy. According to Bass, the county and Labre, in 2009, they found that using therapeutic horse riding demonstrated greater sensory seeking, sensory sensitivity, social motivation, and less inattention, distractibility, and sedentary behaviors in children with autism. We can see that this very unique type of sensory integration therapy technique is not just effective, but also very fun with children. This may open a whole new experience to kids. And if horseback riding is not your thing, we also like to have fun sessions at gyms where we can create opportunities for more social interactions with other kids. For example, in 2015, Kareem and Mohammed used a large gym with equipment such as mats, swings, ball pits, scooter boards, and other similar equipment. This sensory integration program was designed to encourage children to be active and become more comfortable with sensory information. The program reveals significant the program reveals significant and gross and fine motor skills, which help the children become more independent and participate in more in everyday activities.
So SIT is not a treatment plan that can be used by everyone. When it comes to the equipment, clinic space, trained staff, and financial abilities, many clinics are not able to even provide this therapy in the way that it is intended. If a clinic did have the means to provide SIT, it is a technique that has to be done by someone who understands how to implement SIT. Many of the activities and sensory skills done during this treatment involve occupational therapists and other trained professionals.
That's a great point. But not all sensory integration programs need a large space like gyms or horses. This therapy can be used in small rooms without needing a large space. In 1999, Kay Smith and Bryant used vestibular stimulation using suspended swings, tactile brushing, and proprioceptive input to different areas of the children's limbs at the beginning and end of the therapy sessions. The therapy showed to be effective in increasing mastery of play and decreasing non-engaged behaviors, such as impulsive behaviors, stereotypic behaviors, and being unfocused. Overall, I think that sensory integration therapy can be very effective for kids with autism. And before we continue this meeting, I did want to show you guys an example of sensory integration therapy and some of the different types of techniques.
So, unfortunately, still, SIT is not always the best approach for these behaviors. Meta-analyses and compound reviews from 1994 to 2003, according to a 2011 study done by Devlin, Healy, Leader, and Hughes, demonstrates that individuals receiving SIT did not benefit at all from these interventions, and there needs to be more research done on this topic for it to be relevant. As a behavior therapist, I've seen many clients utilize SIT therapy, and it has failed to reduce stereotypical behaviors of children with ASD. For continuously being out of his seat and his impulsive behaviors, he would benefit much greater from behavior therapy with a BCBA. Even if his behaviors look like they could be due to a lack of physical stimulation, it has been shown that SIT alone failed to reduce stereotypic behaviors in children with autism, either with a combination of behavioral techniques or behavioral techniques alone. With the lack of research and overwhelming support for ABA, it's clear that SIT is not an appropriate treatment for Josh.
Hicks, and Wells identified that ABA has the most impact on behavioral and linguistic functioning, however, not in other areas such as cognitive, attention, physical, or social, therefore showing that ABA will only benefit 2 areas versus many. Results from this study showed that most families adopt multiple treatment approaches. Parents were most likely to discontinue non-evidence-based treatments when they did not see improvement in their child's functioning.
Over the years, Cooper, Heron, and Howard, 2007, have ensured that ABA has been well established and developed. This occurred because they have shown that ABA is a science with 6 key components that drive the science and therefore can be replicated to allow for continued success. With that being said, all interventions that are suggested and or put into place have research to back up their effectiveness in treating different target behaviors.
So from the treatments discussed, medication, sensory integration theory, and applied behavior analysis, research demonstrates that applied behavior analysis is the most effective one for individuals with ASD. Because of its long history of data and the science that backs it up, we are suggesting that Josh begin ABA services as soon as possible. This intervention could help significantly reduce his target behaviors by creating a program that is specific and individualized to him. When creating a treatment approach that works best for Josh, our BCBA is well aware of the ethical code violations that they may encounter as well. For instance, boundary of competence, describing conditions for behavior change program success, and least restrictive procedures. With this in mind, our team will create the best possible treatment program to reduce how often he gets out of his seat and any other impulsive behaviors that affect his daily living.
A wonderful idea to address the problem. My husband and I look forward to meeting with the autism team to start the process of starting ABA services.
Now, we as professionals would like to take the time and ask if there are any questions about sensory integration therapy, applied behavior analysis, the medications, or any other details that we have discussed here today.
Everything, I am still unsure about some things. My first question is, what exactly is sensory integration therapy and how specifically will it help my child?
Sensory integration therapy, also known as SIT, is a sensory motor treatment based upon theories that children with autism and other developmental delays experience dysfunction in which sensory input is not integrated or organized appropriately by the brain. Sensory integration is described as providing the child with planned and controlled sensory experiences that aim to produce adaptive and functional responses to sensory stimuli. Current research does not support SI as an effective treatment for children with autism, developmental delays, nor has the research been able to identify SIT as an independent variable responsible for positive change in a child's behavioral skills. In at least one study, SI was shown to actually increase self-injurious behaviors.
My second question is, why is it so difficult to determine what therapy will be best for my child? It seems that all of them would be helpful in some way. How do I choose what's going to be the best for my child?
That is a really good question that you're bringing up, Mrs. Smith. There are so many different options and choices out there that it may seem very overwhelming and almost impossible to decide what is best. The best advice that I can give you is to investigate all of the different types of treatments that are out there and available. There are many different assessment tools that could be used to determine what would be best for Josh based on his needs. Some examples are functional behavior assessment, or an FBA, can be used to determine the function of his behaviors, where there will be a behavior plan put in place to help with those target behaviors. Occupational and speech therapists have their own assessments that they can use to determine if he meets the necessary criteria to receive those services. There are also psychological evaluations, and there are many different types of those that can be completed to determine what services are necessary for him. A final option that you have would be to get a case manager that can help you access all of these services and be able to get through all of the other paperwork and then point you in the right direction for what is best for Josh based on his needs.
Those are really great questions, Mrs. Smith. I'm glad you spoke up about them. At this time, are there any other questions? No, okay, well, then that is a wrap. Thank you all for taking the time out of your busy day to be here, and we will keep in touch when the next IEP meeting date will be. And Mr. and Mrs. Smith, please feel free to call the autism consultant if any other problems arise or additional appointments need to be scheduled. Thanks so much.